right, good morning, Dr. Jaffe. We have a customer writing in with a few questions that all seem to be related to one another. So I'm going to ask this to you as best I can together, and hopefully that will create some conversation around this. So here's what the practitioner is wanting to know. Can false positive reactive items on tests of delayed immune response affect the patient compliance? It sounds like this practitioner is wanting your opinion and maybe your assistance on how this is significant in clinical practice. Is there a psychological effect on the patient when they're not able to follow their plan? And in what ways can difficult programs that possibly have negative effect on the patient's psychology, how can that influence the patient's outcomes?
Thanks for asking. Actually, this is why the LRA by ELISA Act was developed in 1982 and 3 and introduced into clinical medicine, and then the health appraisal questionnaire was validated, and then we brought in full disclosure, high bioavailability supplements through the PERC integrative health aspect of what we do. So what am I saying? What I'm saying is that other systems, for example, serum IgG or ELISA IgG or IG4 or IgG with complement, any serum-based immune test will come up with a very long laundry list of reactive substances, many of which are harmless. That is, these are neutralizing and not harmful reactions. However, when you just measure the presence or the absence of an antibody like IgG or any antibody, you get nothing about, no information as in no information as in nothing about the function. The reason the LRA by ELISA Act was developed as an ex vivo cell culture measuring T cell, B cell, and immune complex reactions was to cut through that confusion. So let's say you take an LRA profile with 375 items. It is rare for someone to react to more than 3 or 4%. In contrast to these serum tests like IgG and related, where you could get half or more of the substance tested it as, quote, positive, and then you're not informed that this was a protective neutralizing antibody that you don't need to pay attention to. And then you could, and I think this is where the questioner was leading, you could end up with failure on the part of the individual. The person would feel they had been wrong, they didn't do good enough. We don't want to blame the victim. We don't want to blame the suffering patient. In fact, we want to evoke their healing response, and we do that systematically. We do that systematically based on what they eat and drink, think, and do. We want them to know where the few items out of many hundreds that they do react to, we want them to know the hidden places where they can avoid that provocation. We want to encourage them to know that many others have had their healing responses evoked, and we never blame the victim. When people say, gee, this runs in my family, the arthritis or the heart disease, oh, it's just my lot in life to get cancer or some other degenerative disease. Gently, and without blaming the victim, we want people to know that enough of the good stuff and an absence of the bad stuff, enough of the essential nutrients in harmony and in balance, and not too much of the anti-nutrient, harmful, pro-oxidative 5 categories of 21st century toxins. And we systematically build all that into an easy to succeed program based on what people eat and what they drink, what they think, and what they do. And over 6 months, we have shown in outcome community-based best effort studies more improvement in type 1 and type 2 diabetics, more improvement in fibromyalgia pain sufferers, and we have hundreds, if not thousands, of anecdotal case reports from colleagues that we share on an individual basis based on the nature of the affliction or the diagnosis from which a person suffers. So we actually documented in our outcome community-based studies extraordinary compliance. And I think that's because we were relevant and specific. I can tell you that for serum tests, the false positive rate is extraordinarily high. Our best clinical information is that for the LRA by ELISA ACT test, based on the few items that come up reactive and how predictive they are of an individual when carefully studied, that we have very few false positives. So we think the false positive issue is a reason to avoid serum antibody tests. We're increasingly confident you need both T and B cell functional information, and you get that from the LRA by ELISA ACT tests. An ex vivo system, measuring reactions just as they occur in the body, standardized over the last 4 decades, reported at the American Society for Investigative Pathology as the most reproducible and precise test of cell culture, of immune function. So we have done what I learned at NIH to do in terms of validation. We are now the gold standard in regard to ex vivo lymphocyte response assay cell cultures. And we urge folks to look carefully at all we have built in to evoke healing responses and to avoid the possibility that a client would feel that they were either to blame or wrong or somehow defective, which is where I think the question started. And we avoid all of that by design. So please look more deeply at what we do. Please do not confuse what we do with others. Please use the more accurate, predictive, personalized, primary, and proactive prevention practices and protocols. And be well.